A 4 weeks old baby is developing well and develop profuse and projectile vomiting after feed. He has been losing weight and vomits is described being non-bilious. What is the most likely underlying pathology? So here we can find the different key point. First of all, there is the profuse and projectile vomiting. Second one is the losing weight, as there is the vomiting, and the third one is the most important, which is the non-bilious. That means the obstruction occurs proximal to the second part of the duodenum. So what may be the answer? Here the options are duodenal atresia, ileal atresia, hypertrophy of the pyloric stenosis, achalasia cardia, intestinal malnutrition. So what may be the answer? So first of all, let's see a picture, draw a picture. Suppose this is a picture. It is the stomach and small intestine, and here we can see in the second part there is opening of the common bile duct. So in this case, as there is non-bilious, that means the obstruction occurs in the proximal part, that means from here up to the second part of the duodenum. And there are different type of the atresia. That may be the duodenal atresia, small bowel atresia, or it may be malrotation. So what is the pyloric stenosis? The pyloric stenosis typically present 2nd to 4th week of the life. That means it not present just after birth. It presents 2nd to 4th week of the life, and it usually present with vomiting, and it causes hypertrophy of the circular muscle of the pylorus. And let's see the epidemiology. It occurs 4 in 1,000 live births, 4 times more common in male baby. 10 to 50% infant have a positive family history, and firstborn are most commonly infected. So these are the most important point, that it occurs 4 in 1,000 live birth, 4 times more common in male, and it first baby 10 to 15% infant have positive family history. And what are the features? The features present projectile vomiting, typically 30 minutes after the feed. Constipation and dehydration may also be present. A palpable mass usually present in the epigastric area. And here develop hypokalemia, and alkalosis. And what is the diagnosis? In case of the diagnosis, ultrasound is enough. So we can diagnose by the ultrasound. And what is the management? Management is this surgery. And the surgery is the Ramstedt pyloromyotomy. That means the muscles in pyloric area, they are splitted. So as they are splitted, the obstruction is removed. So what is our answer? Our answer is the hypertrophy of the pyloric stenosis. And other option here, such as the duodenal atresia. In case of the duodenal atresia, it present very early after the birth, usually 1 to 2 days. And when there is the ileal atresia, it may present 2 to 3 or 2 to 4 days. And when there is intestinal malnutrition, it present within the 4 to 7 days. So when there is more distal, the more time requires. That means, let's see, this is the stomach, duodenum, then small intestine. So when there is in the duodenum, more early clinical feature present. When there is in the ileum and other part, then the clinical feature develop more lately. And when it present in lateral part, that means the intestinal malnutrition, it is more distal. In this condition, the clinical feature present more lately. And in case of the hypertrophic pyloric stenosis, it requires about 1 month to develop. And the achalasia cardia, it is disease of the adult, not in children.